We were supposed to have Dr. Kharbanda, but he's busy somewhere else. So we go international now. And Dr. Meher Rizvi is an associate professor in Muscat. She will give her experience of medical education and the changes they have made in Muscat, Oman. Professor Rizvi, yes.
Good evening, sir. Such a pleasure being with you and with all the other august speakers. It's been a great learning curve for me and absolutely delighted to be here. Suddenly, I was expecting my turn to come after another 20 minutes, but earlier the better. I came here about 7 years ago, and I came with a great attitude that we Indians are the best in the world as far as medical education is concerned. And I was rather upset with the limited amount of microbiology teaching happening here. The here copies the British system, and it is competency based, it is vertical, and naturally everybody has their own, each topic has an aims and objectives, and one is limited by that. However, I found it very difficult and I kind of appended a lot of stuff, and the students went straight to the dean because Sultan Qaboos University is the only public university, and I suppose it's the MCI or everything. So everybody gets very upset here if the students get upset, and a lot of people came over to me and asked me what should be done. I said nothing, I cannot change it any further. Whatever has been done is the minimum which needs to be done to promote best practices and to elevate the level of the students to the world level. So it was very interesting. A lot of conflict happened. The students got really upset. And of course, I learned to be a better human being, shall I say, because in India, for some reason, we are told to be Kadak teachers. We are told to be the stiff, stern Kadak teacher, otherwise the students will take you for a ride. And I found that rather sad when I became a very nice, pleasant teacher over here and tried to do chaplusi, like, please listen to this and understand this. This is something you need to know. And I really wish I had been this nice and this kind to my own Indian students. And I did understand that I wish I had taught more in a simpler English, in sometimes breaking it into Hindi or Urdu as I was working in JNMC and prior to that in MAMC, because it is a real concern, which I think Dr. Deepak did talk about, that English is not our native language, as English is not the native language in this country either. And we must appreciate that. So this country does appreciate it, and it has a foundation course for students who are not fluent in English. And it's kind of a stepping stone. So they have English for medicine, they have chemistry for medicine, and they have a few of other subjects which a student needs to pass. And that tells us that this person has ability to proceed in medicine. If he clears it, it's another 6 years before that person graduates into the MD program. So the MD program in Oman is, the aim is to produce undifferentiated physicians who are prepared to serve the fundamental purposes of medicine and satisfy the contemporary requirements of medical practice and professionalism. Now, currently, this country is very awake to the changes happening in the world, and they're very keen on bringing them in as quickly as possible, which is sometimes quite irritating because you're busy doing something else and then you have to append everything and do something else entirely. So currently what is happening is that the mapping of the program learning, so their program learning objectives, they're being mapped to the course learning objectives, they're being mapped to the student learning objectives. That's happening on one end. And on the other end, they're being mapped to the Sultan Qaboos University graduate attributes and a new body which has developed, which is the Oman Qualification Framework, which is a national framework, so we need to align everybody, all educational institutions need to align their objectives with the Oman Qualification Framework, which makes a lot of sense because everything is online and they want their visibility and they want that things are in place in the right way. What was interesting here is that very active, there's a very active assistant deanship of preclinical and clinical affairs, a very proactive curriculum committee, and a dedicated examination committee, which was kind of very interesting for me. And if I have time later, I'll get into that. The program has 3 main phases: phase 1, phase 2, phase 3. The phase 1 I've already talked about. As I tell you about interesting thing which happens here is that each student is assigned an academic advisor. And that academic advisor remains so for the first 3 years. Advisee, that's a good cross communicate. I mean, communication is open, either student or from the advisor side, and during in-course. So each semester there are a couple of courses happening, and there has to be an in-course assessment in each of those courses. And if we have students who are failing or getting Ds, then a notification is received and by the assistant dean that kindly look into the matter and if remedial action is needed. So there's a very good, what should I say, oversight on how the students are performing. In phase two, in the phase in which I'm teaching, there is vertical and horizontal integration. All system courses are vertically integrated. The practical and tutorials are always in small groups. So there'll be 3 tutorials for a particular session and similarly 3 practicals. And since we're very short of manpower, I mean, very often we just one-man armies. So if I take a lecture, I'll also take 3 tutorials and I'll also take 3 practicals. Now, thankfully, we do have a team. But what was interesting was that I was mapping the entire process and I could understand why it is useful to have the same faculty do tutorials, which of course in India we have the junior people doing it, is because you can see how the information gets distilled from the lecture, how are the students really understanding it, and where we should kind of tweak things. Tutorials are always student directed. That's the beauty of small groups. So it's the students talking to you after doing research. And earlier it was, we're telling them to go to Google. Now we're telling them to even go to ChatGPT. But it's a very interesting link because ChatGPT, the students are accessing, they're coming back and telling us responding to the questions. They're all case-based events and they come back with their answers. We have volunteer leaders, they keep rotating and they come back with their answers. And it's a lovely experience because they say that, okay, ChatGPT told me this, and you can tell them that, all right, ChatGPT is a good assistant, but do understand that your basic is from the books and understand that and then pick up because ChatGPT can lie very well. So it's a good, I feel, a good balance. You welcome the new technology, but also tell them that handle it with care. Do not accept whatever it is saying at face value. And they see it real time. They're seeing it real time because they're doing it with a tutor. So the tutorials can be case-based discussions, can be flipped classroom, can be student presentation. It's a very open system. All coordinators and tutors are allowed to do whatever method is feasible for them. Focus is on active learning. Now, I'm the coordinator of one of the integrated modules, which contributes to the horizontal integration within that semester. For example, if there are 3 system courses running, there will be one integrated module, which is a team-based learning module, which kind of picks up clinical cases from all these, and the students have to participate in it in the team-based learning format. So we have lots of fun during, I think Prof. Biswaroop was talking about it. It is indeed lots of fun. The preparation is where the stress comes in because you're not used to it much. You need to know how to flow with the process. So the clinical examination, a vignette comes up. And then you have to ask the students about the responses through well-crafted MCQs. So to craft an MCQ is not an easy task. And to craft an MCQ, which is like challenging the clinical reasoning and the critical thinking is something else altogether. So the tutor also grows and abundantly, and it's an amazing experience. So just like Dr. Bristol was saying that we provide them with reading material a couple of days prior. They come in for an IRAT, that is individual readiness aptitude test. It can be done on paper. There is no need for an online for a electronic medium. We now have electronic. Earlier, prior to COVID, it was on paper. And then, of course, they do have iPads. So when they respond, they can also respond on paper. They can give their, answers A, B, C, D. So that's the beauty. There's one tutor and there are these 15 teams and you flash the question at the moment when you say at the count of 1 or 3, sorry, they'll all raise their answers. Now, if all of them are, if they're all giving the right answer, the tutor proceeds with the case. If not, then the other teams, the teams themselves discuss and try to convince the other teams on why this is the right answer and not the other. There's also an option of appeal where the question itself or the scenario, there may be some loopholes in it and the tutor now comes in and explains. And again, it's a great experience. So apart from this, the thematic sessions, there is the skill session going on in parallel, where we are training them in early. So the whole thing is early clinical exposure with critical thinking and reasoning and so on. Now the skills start in the second year itself, in the skill session, which is a state-of-art skills lab. And we're teaching them not only the skills, but as I think Sonal was talking about, hand hygiene. So every time they examine a patient, it has to be with hand hygiene and infection prevention control, and also development of soft skills. Like, are you showing respect to the patient? Are you greeting the patient? Are you taking permission before exposing the part? Are you covering the part after the examination? And again, hand hygiene. And all these points are ultimately assessed in OSCE. So you know that by the time they reach the clinical years and practice, this will be part of their DNA. Uh, I think I just have shared a couple of very interesting courses which are being run here. And one is the medical informatics, starts in phase 1, and it takes them down into understanding how the MS Office works, how the computers work, because all the systems here are IT based, and then they come down to using online resources. They learn how to use tools for referencing, and then they, in the second course, they talk about mobile health, evidence-based medicine, clinical practice guidelines, ethics, disease management, registries, and so on. So that's a very interesting thing, because when I came here, I had no clue that students would be given such intensive education and all that. And now, of course, and AI was taught to them prior to ChatGPT came in, and now they're talking about ethics, bioethics, and information ethics in medicine, e-patients, and social media, and so on. Another very interesting development which took place is because of the accreditation program which the college undertook, where a lot of interest, focus is coming on social or community, what is it called? Responsibility. And part of that, we're not, it's not really well fleshed out right now, but after the second year, in their vacations, the students are now being attached to the primary health centers in their villages or their small towns or their towns or whatever. And they've been given this logbook, and the doctors have been told what all exactly they have to be taught. So they're learning, again, a clinical exposure is happening, and the student is going there, giving back to the community in that way, and it is being taken down. It has been accepted, and it is being appreciated by the students. The doctors naturally have to be trained more, but it is, I think, a very, very valuable tool. Now, I was very surprised that the students are taught SPSS as well as the statistical analysis. And then I realized there's a reason for that. And the reason is that they have a research module course which spans over 1 year. So they taught research methodology, which then proceeds to make the students practice what is taught. So they select a list of topics is floated, the same number as a number of students. The student identifies a research topic and is assigned a supervisor for a year. They write the proposal, apply for ethical approval. In summer, before they go for the vacation, it has been applied for. When they come back in September, approval is ready, and they are ready to collect the data and start their work. It could be retrospective, it could be questionnaire based, it could be wet lab based, whatever is the choice of the student. In the third semester, they back to analysis using the skills they have been taught. They write their thesis, they prepare a e-poster, and they prepare, and there is a presentation. So I think one of the, like Deepak was talking about the fact that students don't know how to speak. And that's true, because the hierarchy is so vertical that we actually forbid a lot of persons coming up with a lot of ideas and questions. I mean, I feel at sometimes. So here they're teaching the students in phase 2, that's in the third year of medicine. They're doing all this, and of course tutorials also. They're learning to speak, and it's a beautiful experience. Not only that, their thesis is put into Turnitin to check for plagiarism, and their excellent rubrics. And now with, of course, again, accreditation and people saying that if you have this great thing, why are you not submitting in conferences and publications? So that's happening. My student presented in Geneva because, of course, the university funded it, and publications also coming out of it. Phase 3 is patient-oriented, and which prepares the students for the practice of medicine. which is it starts with phase 2 with the state-of-art skill lab, as well as anatomy lab has a VR lab, which is being used extensively by surgeons. So pre-clerkship is when they come in for 9 weeks. They learn the basics of how to take a history and how to examine a patient. So that it's like and they're assessed. They're assessed in this junior clerkship is being posted from various clinical departments and honing their skills in history taking, examination, and investigations. Senior clerkship again for 48 weeks, and they now get into the management bit again in all those various specialities. What is very interesting, which I really absolutely love, is that they have this I think 8 week or 1 month rotation into the diagnostic departments as senior clerks. That is in year 6 or year 7, depending on which pathway the student took. And they come back to us to microbiology, pathology, biochemistry, genetics, hematology, and so on. And now they've matured. They've seen the patient. They've seen the role which the laboratories play. And now we have mature conversations with them. We've been having case-based discussions earlier, but it was more like force-fed because they didn't know that this would be of use to them later. Now they know it is of use to them, and we have this beautiful what should I say, getting to know each other again with a sense of greater respect that whatever you did teach was actually essential, and thank you for that. And we bring in the antimicrobial stewardship and the diagnostic stewardship again in a very big way. I mean, that's our microbiology context. The other labs will be doing their bit. Another very interesting thing which I do is I meet them again in a very interesting 1.5 hour session, which is fever in a traveling patient, that is returning patient, and you know that everywhere worldwide, travel medicine has become such an important topic which should be taught, and it's again very interactive. Everything, actually the whole thing is that the focus has changed from didactic to interactive. You understand where the students have learned, where they've not learned, and where one should plug in more details. Having said that, so if it's a 7 year and with not the intensive education which we get in India, India is amazing. I don't know how those students learn all those, how they'll end up learning all those various books. Hats off to them. It cannot be done here for whatever reason. But yes, I do understand one very difficult problem here, and that is the semester is usually 3 and 3.5 months, 3.5 months. And so you have to, for example, if it's HNS, if it is the respiratory system, if it's cardiovascular, you have to ace it. You have to learn it within those three. When you're learning 3 different courses, some systems in that same semester, that means you have to have that skill to just take it in and then just regurgitate out at the time of the exam. And then when you meet them after 1 year or even after the next semester and they can't remember it because there's no opportunity to get that long-term memory going. And what they don't have is that end of phase exam. And that's again because of shortage of manpower and so many other things. But that's where I think there's a big limitation. So if time allows later, I'll talk about the assessment.
I think
Otherwise,
we need to move on. So
yes.
we'll move on to UAE now and to Hafiz. Thank you, Meher.